Good morning, and welcome to this meeting of the Physicians Focused Payment Model Technical Advisory Committee, known as PTAC. My name is Angelo Sinopoli, and I'm one of the co-chairs of PTAC, along with Lauren Harden sitting here beside me. Since 2020, PTAC has been looking across its portfolio to explore themes that have emerged from proposals received from the public over the years. After each theme, the committee releases a public report to the Secretary of HHS with its findings. In March, PTAC released its report to the Secretary on optimizing population-based total cost of care models, and I encourage you to find it on the PTAC website. Back in June of 2021, PTAC explored care coordination through one of the theme-based discussions, and care coordination has continued to come up at probably every one of our public meetings since then. Also, given that the Innovation Center at the Centers for Medicare and Medicaid Services is focused on driving accountable care, PTAC is continuing to explore key issues related to the population-based total cost of care models. We decided to organize this public meeting around diving into how management of care transitions can be improved specifically within the population-based context. Before our first presentation of the day, we're honored to have opening remarks from Dr. Liz Fowler, the Deputy Administrator of CMS and Director of the Center for Medicare and Medicaid Innovation. Dr. Fowler previously served as Executive Vice President of Programs at the Commonwealth Fund and Vice President for Global Health Policy at Johnson & Johnson. She was Special Assistant to President Obama on Healthcare and Economic Policy at the National Economic Council. From 2008 to 2010, she also served as Chief Health Counsel to the Senate Finance Committee Chair, where she played a critical role in developing the Senate version of the Affordable Care Act. Welcome, Liz.
Thanks so much, Dr. Sinopoli, and welcome everyone, and thanks so much for being here today. I'm sorry I'm not there with you in person this morning. Before diving into today's meeting, I just want to take a moment and thank PTAC and all the speakers from the March meeting for the really valuable input from that session. As I mentioned in March, the Innovation Center's Specialty Care Integration Team has been working on a specialty care strategy to drive better integration of primary and specialty care to serve those with chronic or serious conditions through our models. And at the March meeting, the last time we were together, the team posed the following questions for PTAC's consideration. What are the current challenges related to specialty integration and advanced primary care models and ACOs? What strategies and approaches would best support increasing specialty care provider engagement in ACOs where specialists share accountability with primary care providers for providing high value care and bearing appropriate financial responsibility for patient outcomes? How should high value specialty care be defined, and what are the appropriate performance measures for assessing specialty integration? And I'm really pleased to support that a lot of the conversation and discussion at the March session is helping us to answer these questions. So just a round of thanks again. Of course, there's still a lot of outstanding questions to be answered as part of that strategy, but the March meeting was really immensely helpful, and we look forward to ongoing discussion. And that's why I'm also looking forward to building on our previous sessions over the next 2 days, as this focus is turned to improving care transitions management within population-based total cost of care models. The topics outlined to be discussed are really right on target in my view. Innovative approaches for improving management of care transitions across settings of care, financial incentives for improving care transition management, addressing care transitions in APM design, and then also measuring care transition quality. Staff from across the Innovation Center are live streaming the public session, and I look forward to hearing a report of today's robust and informative conversations. Before closing, I just wanted to provide an update on the Innovation Center's new primary care model that we announced last week, called the Making Care Primary, or MCP model. The model is set to launch on July 1st, 2024. The Making Care Primary model is built on the foundation of over 10 years of testing primary care models, the CPC, CPC Plus, and current Primary Care First models, to make advanced primary care available and more sustainable for smaller, independent practices serving a diverse set of patients to improve quality, health equity, and overall patient care. Some of the distinguishing features of MCP compared to previous CMMI and current CMMI primary care models include, first of all, an on-ramp for primary care providers and practices who are new to value-based care. The model includes an explicit focus on smaller independent practices and safety net organizations, including FQHCs, many of whom are serving rural areas. And for eligible providers, the model will provide upfront infrastructure payments. State partnership, previous models have had a broad geographic scope, and MCP is focused on fewer states and a greater depth. We announced 8 states participating in the model: Colorado, North Carolina, New Jersey, New Mexico, New York, Minnesota, Washington, and Massachusetts. And we're actively working with state Medicaid agencies to achieve meaningful multi-payer alignment. These states have agreed to align with CMS in areas of quality measurement, data sharing, and learning supports, and a move away from fee-for-service. Third, a longer model test. So as all of you in the room know and on the line know, it takes time to demonstrate results and achieve transformation, and particularly in parts of the health system that have been historically under-resourced. And for that reason, we've set the model to run for 10 years compared to our usual 5 years. And then finally, related to last March's topic, we're really looking at integration of primary care and specialty care as part of this model. The model includes elements and strategies to drive better integration of primary and specialty care to serve those with chronic or serious health conditions. And this includes supporting electronic consultations between primary and specialty providers, and co-management for those with chronic conditions that require primary and specialty care to work together. The model creates upfront financial support to practices, as I mentioned, to deliver whole person comprehensive care, but it also creates a pathway for participants to adopt prospective population-based payments and gradually assume greater responsibility and accountability for their patient populations. And it does this by creating 3 tracks with the expectation that providers will move up the track as the model progresses. The first track is building infrastructure and is reserved for participants with no prior value-based care experience. And participants will begin to develop the foundation for implementing advanced primary care services, such as risk stratifying their population, reviewing data, building out workflows, identifying staff for chronic disease management, and conducting health-related social needs screenings. Certain eligible organizations in Track 1 might also receive a one-time upfront infrastructure payment meant to support investment in tools and staffing needed to support care transformation. Track 2 is really implementing advanced primary care, and we expect participants in this track to partner with social service providers and specialists, implement care management services, and systematically screen for behavioral health conditions. And then Track 3 is really optimizing care and partnerships. And in this track, we expand on the requirements of Track 1 and 2 by using quality improvement frameworks to optimize and improve workflows, improve care integration, develop social services and specialty care partnerships, and really deepen those connections with community resources. We're planning on releasing more details in the coming months. Our application period will open later this summer with the release of the request for application. And for more information on how we see the primary care model fitting in with our larger strategy, you can find a blog on this topic on the CMS Innovation Center's website. It outlines our portfolio-wide primary care strategy and the goals to strengthening primary care infrastructure in the United States by really creating multiple pathways to support improved financing for advanced primary care, equitable access to high-quality primary care, and sustainable transformation across a wide variety of practices. And the paper provides an overview of the Making Care Primary model, which is designed with this strategy in mind. So I think that's maybe a good note to end on. I'll stop there and turn it back to Dr. Sinopoli. And thank you again for inviting me to join you today. And I'm really looking forward to hearing more about the care transitions and from all the speakers you have lined up.
Thank you, Liz, for sharing all that. We look forward to hearing more about that over time. And we just want to say that we really appreciate how engaged CMS has been with PTAC, and we look forward to continuing to work with you and your team. Very much appreciate it. For today's agenda, we'll explore a range of topics, including effective care delivery models and strategies that improve the management of care transitions, and how we can structure financial incentives and performance measures to incentivize adoption of these innovative approaches. The background materials for this public meeting, including environmental scan, are online. Over the next 2 days, we'll hear from many esteemed experts. We have worked hard to include a variety of perspectives throughout the 2-day meeting, including the viewpoints of previous PTAC proposal submitters who addressed relevant issues in their proposed models. I want to mention that tomorrow afternoon we'll include a public comment period. Public comments will be limited to 3 minutes each. If you'd like to give an oral public comment tomorrow but have not yet registered to do so, please email ptacregistration@norc.org. Again, that's ptacregistration@norc.org. The discussion materials and public comments from the June PTAC public meetings will all feed into a report to the Secretary of HHS on how to improve management of care transitions and population-based models. The agenda for today and tomorrow includes time for committees to discuss and shape our comments for the upcoming report. Before we adjourn tomorrow, we'll announce a request for input, which is an opportunity for the stakeholders to provide written comments to the Committee on Improving Care Transitions. Lastly, I'll note that, as always, the committee is poised and ready to receive proposals on possible innovative approaches and solutions related to care delivery, payments, and other policy issues from the public on a rolling basis. We offer 2 proposal submission tracks for submitters to provide flexibility depending on the level of detail available about their payment methodology. You can find information about how to submit a proposal online. At this time, I'd like my fellow PTAC members to please introduce themselves. Please share your name, your organization, and if you'd like, feel free to describe any experience you have with our topic. First, I'll go around the table, and then I'll ask our members joining remotely to introduce themselves. I'll start. I'm Angelo Sinopoli. I'm a pulmonary critical care physician by training, presently the Chief Network Officer of Upstream. It is a value-based risk-taking organization. We do support many rural primary care physicians in managing global risk in their practices. Prior to that, I ran a very large network of 5,000 physicians across 2/3 of South Carolina, which, as you can imagine, was also very rural and tackled a lot of these problems. So I'm very interested to hear our speakers today. Next is Lauren.
Good morning. I'm Lauren Harden. I'm a nurse by training and Chief Integration Officer for HC2 Strategies. I've spent the better part of the last 20 years really focused on building care management and value-based payment with ACOs, MSSP, Pioneer, also BPCI, and then have worked on model building in partnership with states, government, communities, multi-state health systems, really focused on populations who are disproportionately affected by health disparities. I'll go to Lindsay.
Good morning. I'm Lindsay Botsford. I'm a family physician by training and currently a market medical director with One Medical. I'm based in Houston, Texas.
Good morning. Jim Walton. I'm a general internist by training. I currently am the president of my own consulting firm in healthcare. My background is a rural healthcare provider in Waxahachie, Texas, health system executive for Chief Health Equity Officer at Baylor Healthcare System, and I ran a large IPA and ACO for about 10 years in the greater Dallas area, which included some smaller semi-rural spaces.
Good morning, everyone. My name is Joshua Liao. I'm an internal medicine physician based in Seattle at the University of Washington. There, I also lead an evaluation research group that studies value-based payment models like ACOs and bundle payments, work with state stakeholders and decision makers on value-based policy. Outside of that, I also serve as an enterprise medical director for payment strategy, so implement models and work with our population health and value-based care teams on aligned strategies.
Good morning, everyone. I'm Chinny Puller. I'm a family physician by trade. I'm Vice President of Clinical Operations and Chief Clinical Executive for the Walmart Health Omnichannel business. I lead our care provider entities as well as clinical operations in clinics, telehealth, and social determinants of health. Prior to that, I served to lead the clinical aspects of one of the largest provider medical groups integrated in the U.S. named DuPage Medical Group, now Dewey Health and Care, and led a lot of their value-based care platforms end to end.
Good morning, everyone. My name is Jay Feldstein. I'm currently the president of Philadelphia College of Osteopathic Medicine, trained in emergency medicine. And prior to my current experience, I spent 15 years in the health insurance world, the last 5 running Medicaid plans in 5 states, and have a lot of experience in fully capitated and shared risk arrangements. Thank you.
Good morning. I'm Jennifer Weiler. I'm the Chief Quality Officer in the Metro region for UC Health. I'm also co-founder of the Health Systems Care Innovation Center, where we partner with digital health companies to grow and scale solutions to improve outcomes for patients. I'm a tenured professor at the University of Colorado School of Medicine, and I was a co-developer of an alternative payment model reviewed by this committee.
Good morning. I'm Terry Lee Mills. I'm a family physician, currently Senior Vice President and Chief Medical Officer at Community Care of Oklahoma, a provider-owned regional health plan offering commercial, ACA marketplace, and Medicare Advantage plans on a fully capitated total cost of care basis. My background is in rural primary care in South Central Kansas, and over my career I've practiced, operated, and led transformative and APMs, including medical neighborhood, early on CPCI, CPC Plus, Primary Care First, and multiple MSSP programs.
I'm Larry Kaczynski. I'm a gastroenterologist by training. I spent my entire career in private practice in the northwest suburbs of Chicago and helped build the largest GI practice in Illinois. For the last 10 years, I've been focused on value-based care, and I'm currently the founder and chief medical officer of Sonar MD, a full risk company that is focused on disease management and care coordination and disease management in gastrointestinal diseases. And I'm proud to say that Project Sonar that started our company was the first PTAC recommended physician-focused payment model back in 2017.
Good morning, everyone. My name is Walter Lin. I'm the founder of Generation Clinical Partners. We are a group of medical providers based in St. Louis, caring for the frail elderly in nursing homes and assisted living. It's often very multi-morbid population, and we do quite a bit of post-acute care work as well. So the topic at hand, care transitions, is near and dear to my heart.
So thank you. I don't believe we have anybody online. I think everybody's here. So let's move on to our first presentation. 5 PTAC members served on a preliminary comments development team, or PCD team, which has worked closely with staff to prepare for this meeting. Walter, who you just heard from, led the PCD team participation with Jim, Jen, Lindsay, and Lauren. I'm thankful for the time and effort they put into organizing today's agenda and presentation. It was a lot of work. We'll begin with the PCD team presenting some of the findings from their analysis. Additional background materials are available on the ASPE PTAC website. PTAC members, you will have an opportunity to ask the PCD team any follow-up questions after the presentation. And now I'll turn it over to the PCT team lead, Walter.
Thank you, Angelo. And before I begin my remarks, I do want to echo Angelo's thanks to the PCDT team, the ASPE staff, and the NORC staff for the tremendous amount of work, not only putting together this presentation, but also in organizing the hopefully outstanding 2-day meeting that we're about to have on this really important topic. So just thank you for this, for all the hard work. In terms of meeting objectives, the goal for this public meeting is to better understand how financial incentives and alternative payment models can be structured to incentivize improvements in care transition management between settings of care. To achieve this goal, we have invited a number of experts and national thought leaders to address how best to overcome barriers to improving care transition management through financial incentives. Topics that will be covered include opportunities and barriers to improve care transition management, effective care transitions delivery model innovations and strategies, payment strategies that can be leveraged to improve care transitions management, and care transitions performance metrics that should be monitored for driving quality improvement, standardizing best practices, and facilitate benchmarking. In terms of the agenda for this PCDT presentation, I will first discuss some definitions and background information related to care transitions. Next, I'll present findings from an updated analysis of transitional care management services amongst Medicare fee-for-service beneficiaries, recently completed by the ASBE and NORC teams. This will be followed by a brief discussion on the components of an effective care transitions program. And finally, I'll conclude with some thoughts that the PCDT team had on payment model challenges related to care transitions. First, it is important to address why PTAC is focusing on this topic. As Angelo mentioned, several of PTAC's prior public meetings have addressed issues related to improving care coordination, care delivery model design, and primary and specialty care integration in alternative payment models. Additionally, PTAC has deliberated on 28 proposed physician-focused payment models that met the Secretary's 10 regulatory criteria, one of which is integration and care coordination. Many of these proposals described issues and payment design solutions related to improving care transitions management. Thus, PTAC felt it important to devote a full public meeting to improving care transitions management through payment model design. PTAC's working definition of care transitions is the movement of a patient from one setting of care to another, such as from a hospital to a post-acute care facility or to a patient's home. Patients often have not just one, but multiple care transitions during an episode of care, and at each point there is a risk for patient harm and adverse outcomes if not done properly. Care transitions management is the ongoing support of patients and their families over time as they navigate care and relationships amongst more than one provider, healthcare setting, and or more than one healthcare service within the same or different facilities. These services should include patient-centered interventions before, during, and after the transition that is tailored to the patient's acute condition, chronic comorbidities, and social determinants of health factors. The objective of effective care transitions management are to, number one, improve quality and patient outcome and reduce patient harm. We also want to see improved patient experience through patient-centered interventions, accounting for social determinants of health factors. Thirdly, improve provider experience, ideally through the use of an interdisciplinary team to improve efficiency and reduce burnout. We also like to see improved population health by investing in infrastructure to coordinate care across settings with a focus on equity and higher risk populations such as racial and ethnic minorities, older adults, individuals who are dually eligible for Medicare and Medicaid, and individuals with limited English proficiency. And finally, but very importantly, reduce spending by decreasing avoidable readmissions and ER visits and increasing healthy days at home. Components of an effective care transitions management program include screening and risk stratification to identify high-risk patients, thorough medication reconciliation to reduce harm from medication errors, communication and collaboration with the patient's healthcare team, caretakers, and family, timely follow-up visits, and patient and caregiver education. Foundational to an effective care transitions management program is the complete and timely transfer of health information from one setting of care to the next. Intuitively, the more settings that a patient receives care in, the more difficult it is to achieve this goal of accurate health information transfer, and as a result, the more likely an adverse patient outcome or medical error will occur. At the risk of oversimplification, this is not dissimilar to what happens in the children's game of telephone in my mind. This slide depicts an idealized example of a care transitions journey for a patient after a stroke. The patient unfortunately suffers a life-changing stroke with functional or cognitive deficits and is admitted to the hospital for treatment. Once treatment is complete, the patient is stable, he or she is discharged to a post-acute skilled rehabilitation facility, followed by discharge home after achieving their goals of care. The patient initially may or may not receive home health services after discharge home. And after completion of this episode of care, the patient receives ongoing outpatient care in the community from his or her PCP and specialist. Now, in this idealized example, no medical errors in any of the patient's care settings occur, and health information is transferred seamlessly, accurately, completely, and in a timely fashion to achieve perfect handoffs between each setting of care. The patient also develops no complications during this episode of care and is able to proceed linearly to progressively lower levels of care without any setbacks. As we all know, a patient's care journey is often far from this idealized example, and in fact may look more like this. This diagram depicts the many different destinations the same stroke patient may be discharged to. Example settings in this diagram are not intended to be exhaustive. The light blue boxes in this slide show the linear path demonstrated in the prior slide, while the dark blue boxes show other potential destinations the patient may be discharged to. Also note that at each stop along the patient's episode of care, there is a risk of readmission to the acute care hospital, which may start the patient's whole care transitions journey over again. There are literally hundreds of different permutations a patient's episode of care can take, and each stop along the way requires active care transitions management with effective and timely transfer of health information with goals of care in order to optimize the patient's health outcomes. This is why care transitions management is so difficult. From a payment model perspective, patients frequently are treated in multiple care settings by multiple providers. These relationships may not be accounted for under existing attribution approaches, which tend to focus on the provider furnishing the plurality of care or the provider furnishing care during an anchor event or procedure. Next, I'd like to present some findings from an updated analysis of transitional care management services among Medicare fee-for-service providers, recently completed by ASPE and NORC teams. I am actually very excited to share some of these new findings that I know will help shape the discussions with our experts over the course of our ensuing two-day meeting. First, some more background. This slide provides an overview of Medicare enrollment. In 2021, there were approximately 64 million Medicare beneficiaries, of which 58 million had both Medicare Part A and Part B. The first pie chart shows that a bit over half of all Medicare beneficiaries were in traditional Medicare as opposed to Medicare Advantage. The second pie chart shows that all the beneficiaries in traditional Medicare the second pie chart shows that of all the beneficiaries in traditional Medicare, 57% were not in a value-based arrangement like an ACO. In other words, in 2021, over a quarter of Medicare beneficiaries were still in traditional fee-for-service Medicare. Although this number is expected to shrink over time, it is still quite sizable and thus highlights the importance of improving care transitions management for Medicare beneficiaries in both value-based arrangements as well as traditional fee-for-service Medicare. So why is it important to focus on care transitions management? Put simply, overwhelming evidence has shown that care transitions interventions are associated with substantial cost savings without reducing access or quality. For example, the care transitions intervention, a patient-centered coaching intervention, has been associated with 22% lower total healthcare costs at 6 months. The University of Pennsylvania's transitional care model was also associated with up to a $4,000 lower average total care cost per patient at 6 months. We are pleased to have Dr. Mary Naylor, who designed this model, as a subject matter expert during this meeting. In 2013, Medicare introduced 2 TCM billing codes to reimburse providers for assisting patients during the transition from an approved inpatient setting to a community setting of care. To bill for these codes, a provider has to, number 1, communicate with the patient or caregiver within 2 business days of discharge. Number 2, make medical decisions of moderate or high complexity. And number 3, have a face-to-face visit within 7 or 14 days, depending on the patient's complexity. We are pleased to have Dr. Robert Zorowitz, a co-author of the original TCM codes, as a subject matter expert during this meeting. Now, prior studies have shown that uptake of TCM codes has been slow, possibly because of the relative cost of providing transitional care services versus the financial incentives of providing these services. There's also been a documented lack of interoperability between electronic health records, making TCM services time-consuming and challenging. And there have also been eligibility and coinsurance requirements that may be a barrier as well. A March 2022 descriptive analysis conducted for PTAC examined the use of TCM codes in 2019, which was 6 years after these codes were first introduced. This analysis found that less than 1 in 5 potentially eligible Medicare beneficiaries received TCM services, as evidenced by the billing of these codes. Larger practices were more likely to bill for TCM services. Practices that were affiliated with an ACO were more likely to bill for providing TCM services. And similarly, practices that were affiliated with an ACO billed for higher proportions of their beneficiaries who were potentially eligible for TCM. The major takeaway from this study was that Medicare TCM services were likely not provided to many fee-for-service beneficiaries who might have benefited from them. Now for the exciting new news. A new June 2023 analysis, hot off the press, examined the impact of the use of these TCM codes on outcomes during the 2-year period of 2018 to 2019. Let me first give some background on the study methodology. The unit of analysis was episodes that began from a qualifying discharge that was eligible for TCM services after an index short-term acute care hospitalization and ended 60 days after discharge. Results were compared for beneficiaries who received TCM services within 30 days and a similar comparison group that did not receive TCM services following discharge. The headline is that this new analysis found that those beneficiaries who received TCM services within 30 days had statistically significant lower hospital readmission rates, lower total cost of care per episode, and more healthy days at home. There was a significant decrease of 13.7%, or almost $1,000, in the total cost of care per episode during the 60-day period following discharge. This analysis provides further evidence that TCM services, as delivered in the real-world setting as opposed to an idealized academic study, are also associated with positive patient outcomes including substantial cost savings. Taken as a whole, these two analyses by the ASPE and NORC staff teams show that, number one, Medicare TCM services were likely not provided to many fee-for-service beneficiaries who might have benefited from them. Number two, practices that were affiliated with a ACO were more likely to bill for TCM services. And number three, use of these services within 30 days of hospital discharge was associated with significant improvement in outcomes. I invite our audience to think through the implications of these findings and also very much look forward to discussing these implications with our experts over the next 2 days. I'd like to now turn our attention to components of effective care transitions models from the PCDT environmental scan on this topic. So the good news is that from a clinical perspective, we have ample evidence that care transitions management program works. This slide shows 4 examples of care transitions delivery models which have been extensively studied in the literature. These include the transitional care model from the University of Pennsylvania School of Nursing, Project Boost from the Society of Hospital Medicine, Care Transitions Intervention Model from the University of Colorado School of Medicine, and Project Reengineered Discharge, or Project RED, from the Boston University Medical Center. This list is not intended to be exhaustive by any means, but the key takeaway is that effective evidence-based care transitions models are in use, but unfortunately have not been widely implemented. The question for our experts is, how can payment model design help close the implementation gap between best evidence and current practice around care transitions? This slide illustrates some selected facilitators of care transitions management, which include collaborating within and across organizations, tailoring services to patients and caregivers, and generating staff buy-in. Successful care transitions delivery models leverage interdisciplinary team-based care to coordinate care and community services across different settings of care. They facilitate complete and efficient transfer of information, as previously discussed. They also encourage effective communication with the patient and caregivers, both in person as well as telephonically or remotely. These models also tailor comprehensive patient and caregiver education and promote their active involvement in care planning. And of course, staff buy-in and prioritization of care transitions services is critical to the success of these models, given the many competing interests providers face, limited resources, and the need for timeliness of provision of these services for them to achieve maximal impact. What are some care delivery challenges related to improving care transitions management? They include communication breakdowns, unplanned discharges from the hospitals, disparities in care transitions management resources, insufficient health information infrastructure, technology, and data analytics, gaps in access to post-discharge care, particularly in rural and underserved areas, limited patient awareness of care coordination staff and services, workforce availability and staffing turnover, and perhaps most importantly, in my view, lack of accountability, particularly in the traditional fee-for-service Medicare model. So the way the PCDT team has thought about enabling effective care transitions is to establish effective policy goals and payment models, such as increasing accountability and optimizing financial incentives. This is detailed in the first dark blue box. In our vision, this will serve as the catalyst through which care transitions delivery processes can be transformed. The second box, the middle box, which will ultimately result in improved quality, and health outcomes as detailed in the third box. Now, the focus of this public meeting is the first box. We feel that by getting policy goals and payment policies right, delivery processes will be optimized and quality and health outcomes will be achieved downstream to that. Finally, I will conclude my remarks with some care transitions payment model challenges. Let's start by first acknowledging that there are many payment models in play that support care transitions. From less risk to more risk, these include the Medicare TCM services, which I just described, bundled payments for care improvement, or BPCI, advanced model design, accountable care organizations, and finally, Medicare Advantage. In addition, many current and prior Medicare programs encourage effective care transitions management through payments and penalties. These include the Hospital Readmissions Reduction Program, or HRRP, the Skilled Nursing Facility Value-Based Purchasing Program, or SNF VBP, and Community-Based Care Transitions Program, or CCTP. Suffice it to say that Medicare has extensive experience in payment models supporting care transitions. It is also true that there is much variation in care transitions outcomes, both quality and financial outcomes, between different payment models and even between different organizations in the same payment model. The goal of this public meeting is to hear from our experts on how to make payment policy recommendations to better achieve optimal care transitions outcomes across the board, both under fee-for-service as well as value-based models. This slide provides an overview of payment model challenges related to improving care transitions management. These include limited and/or conflicting financial incentives for providing care transitions management activities, especially in the traditional fee-for-service setting, determining accountability for care transitions quality and spending when multiple providers are involved from multiple different settings, establishing optimal degree of flexibility in participation requirements related to care transitions management, and structuring financial incentives for participating providers, and identifying meaningful performance measures to evaluate the quality of care transition management activities. The following slides will provide additional details on each of these payment model challenges. From a limited and/or conflicting financial incentives perspective, there are currently limitations on who can provide TCM services. Often TCM services are focused solely in the primary care provider realm, especially from a billing and reimbursement perspective, whereas in reality, multiple specialists as well as a wider interdisciplinary team might be involved. There are also issues regarding the cost of providing TCM services versus the available reimbursement for these services, especially under the traditional fee-for-service setting. There are pressures to reduce lengths of stay in hospitals and post-acute care facilities, and to discharge patients to less intensive settings of care, as well as to reduce readmissions. And finally, very importantly, under fee-for-service Medicare, TCM reimbursement is not tied to outcomes. In terms of assigning accountability for care transitions, in theory, there's really no accountability for outcomes or spending under fee-for-service Medicare. Beneficiaries who are not attributed to a value-based program may experience worse management of care transitions and have poor outcomes related to care transitions, as suggested by the recent ASPE analysis. Multiple providers may also contribute to a patient's care transitions journey, and attribution based on plurality of services or first touch may not account for all the contributing providers. As an example, a patient who receives joint replacement surgery might be in an attribution approach based on plurality of services and thus may align to a primary care provider, but not to the hospital or post-acute care setting involved in their surgery or rehabilitative care. Similarly, under a first touch approach, a patient might be attributed to their admitting provider, but not to their discharging provider or primary care provider, who can also influence the patient's quality of care and financial outcomes. Even under value-based models like ACOs and Medicare Advantage plans, participants can address accountability for care transitions by sharing quality performance data or distribute shared savings or losses amongst participating providers, but they are not required to do so, and so performance information is often limited even in these settings of care. With respect to establishing optimal degree of flexibility, patient-centered care may necessitate different approaches to care transition management, such as for patients with multiple chronic conditions, with high or rising risk, with conditions requiring acute or chronic management, in underserved areas, or with issues in access to care. The patient panel mix may vary substantially amongst providers and regions, which should be taken into account. Requirements around provision of evidence-based services in order to receive add-on payment versus the ability to use add-on payment to provide tailored services based upon a patient panel's needs should be addressed. From measures and metrics perspective, there are a lot of examples out there already around possible care transition performance measures. These include care process measures such as medication reconciliation, communication about discharge information, utilization measures such as ED visits, avoidable hospital readmissions, post-acute care utilization, and home health visits. Spending measures such as total cost of care and setting-specific spending measures, and health outcome measures such as mortality, frailty, change in functional status, receipt of follow-up cares, and healthy days at home. And finally, patient-reported outcomes such as patient experience with care. Examples of technical issues affecting implementation of meaningful performance measures in general are well known, and I won't detail them too much here, except to say from a high level, these include balancing specificity and usability. This includes sample size issues, which affect low volume providers, as well as some condition specific measures. Data collection burden, capturing patient reported outcome measures can often be burdensome, but are very important. Defining person-centered goals and indicators, and there's also some question about the applicability of absolute versus relative scales for providers serving certain different populations. So some options for addressing these previously discussed payment model challenges include sharing benchmarked financial and performance data in a timely manner, especially performance data that can affect predictive algorithms and risk stratification. These might include transitional care management utilization rates, 30-day readmission rates to the hospital, ER visits, Medicare spending per beneficiary metrics, and healthy days at home. Payment design features that shift risk to providers in the traditional fee-for-service environment could also encourage the wider implementation of care transitions activities by tying TCM payments and/or bonuses to outcomes. The whole idea of shifting fee-for-service providers to risk-based relationships is essential to value-based care. Creating models of care that support care transitions innovation include funding non-physician roles, expanding the SNF 3-day rule waivers, and skill in place programs, and more recently, hospital at home programs. And finally, defining and disseminating care transitions best practices include things like understanding the role of interdisciplinary teams, studying transitional care performance under bundle payments, ACOs, and Medicare Advantage to learn best practices and disseminate them, and also learn from the rollout of Medicare Advantage's transitional of care metric. Ultimately, at its core, the journey to value-based care involves increasingly tying patient outcomes to payment. Over the next few days, PTAC hopes to learn from our invited experts on how to better do this for the important area of care transitions management to improve care transitions not only for the Medicare fee-for-service population, but also under value-based care models. We'd also like to hear from our experts on why they think providers and value-based care organizations perform better care transition management services than fee-for-service providers. With that, that concludes my remarks. I'll turn it back over to you, Angelo.
Good. Thank you, Walter. That was a great presentation and sets us up very well for the next 2 days. Appreciate that and all the work the PCD team members put into it. We only have a few minutes left, but before I open it up to PTAC members in general, I just wanted to see if the PCD team members had anything to add to that presentation. If not, then do any of the PTAC members have any questions?
Walter, that was an excellent presentation, such a wonderful foundation. I was very intrigued when you began to talk about creativity in TCM models and addressed one recommendation of funding non-physician roles in care models. I'm curious what trends you saw in that in review of the evidence, and then also how could that potentially impact longitudinal care, which we've seen as a real benefit for consistency and quality?
Lauren, that's a great question, and I'd like to open it up to my PCD team members and ASB staff as well. But I'll take a first pass at that. So in terms of funding non-physician roles, I think one of the things that we saw clearly in our environmental scan is the key role the interdisciplinary team plays in successful care transitions management programs. That being said, under fee-for-service management, there aren't very many funding mechanisms for non-physician roles. And so I think that is an area ripe for exploration. And perhaps one of the reasons why ACOs and other value-based care payment models perform better in care transitions outcomes is because of their ability to fund non-physician roles.
Any other questions? If not, I want to go ahead. Go ahead.
Excellent presentation. I really enjoyed it. You covered it in detail. Your study that you presented at the beginning showed the positive effect of an organization that has accountability in improving transitions, lowering costs, improving quality. I struggle with the opposite end. The number of readmissions to hospitals that occur without one claim-based encounter between the discharge and the readmission. It's a lot more common than we would imagine. And, you know, it's great that we have a positive outcome, but we really have to focus on those negative ones. It's a big problem.
Yeah, Larry, thank you for that. I agree. It was sobering to see the ASPE and NORC analysis that as recently as 2019, less than 1 in 5 eligible Medicare beneficiaries received these services that have such a big impact on both quality and financial outcomes. And it was also very interesting that beneficiaries in risk-based models like ACOs receive more services than fee-for-service models. And so I think, in my view, ultimately the answer is to shift more and more fee-for-service providers to value-based arrangements. I know that is also a CMMI goal by 2030 as well. 100% will be in some sort of value-based relationship. But in the interim, there's still a significant number of traditional fee-for-service beneficiaries who are not receiving the benefit of transitional care management services. And we really look forward to exploring the reasons why with our experts and potentially coming up with some innovative solutions over the next few days that we can make recommendations to the Secretary.
Yeah, Walter, I'd like to comment. I think that, kind of following what Larry was talking about, that the barrier for primary care physicians to actually participate in value-based arrangements has really fallen over, my experience, 4, 5, 6 years, and it's drifted downward where it's fairly easy and pretty low impact because there's enough infrastructure organizations to provide the wraparound support that lowers the burden to do that, to be a primary care doctor in a value-based arrangement and be successful. The whole theory of moving the money, for a doctor from here to here, and as a mechanism, right? As a mechanism to say, we want you to take on these new things, and we want you to focus on these new activities in addition to running your business. And the reason we feel so strongly about it, we're going to put that money right over here. I think that what you're suggesting with TCM, right, I think is the right approach, which is move the TCM payments, maybe even increase them somehow so that doctors are going to go, okay, not only will I do that work because it saves money, it reduces the readmissions, it improves quality, right? I'm going to do that work, but I'm going to do it through an organization that gives me support so that I can actually optimize the care of my patients. I think that's kind of gets to the payment model that we were advised. So thank you so much for, I think if I'm interpreting correctly, I may misinterpret it, but that's what I got.
Jeannie?
Thank you, Walter, and the entire team. This is an excellent. I wanted to highlight one thing that you talked about with barriers that I think, I'd like to double click into. Insufficient health information technology infrastructure and data analytics. I feel this is so foundational to our ability to do this in any construct. And one of the things we had in my old world was when we tried to form a high-performing post-acute network, we had the hardest time getting people to get us feeds or ADT feeds on admission, discharges, or any sort of information in order to be able to react to it. So the question is, how do you see that being able to be enabled better, given some of the barriers that are there? Because it seems like it's so foundational if you want to go into fee-for-service infrastructure.
Yeah, Ginny, I don't have an easy answer to that. This is a huge problem and well known, but I think especially acute in the transitions of care world because of the importance of having health information at the time of the care transitions visit. And so I look forward to exploring that with our experts.
So we only have 1 minute left. Wait.
Thank you, Angelo. I'm going to, Walter, return to something Jim was saying, which just has really struck me that, one of the drawbacks to some of the advanced models are just that they're very complex to operate. High data needs, high analytic needs, high infrastructure needs, and they're just very, very hard, especially for rural providers, to have that type of infrastructure. what we have here in the analysis from ASPE-NORC about TCM codes is incredibly powerful. It's a specific single service providing the most valuable piece of most advanced practice models, which is the transition of care, managing, if you will, the white space in the health economics of the org chart is incredibly powerful. And it showed that just that single service, managing that transition, saves money, prevents hospitalizations, et cetera. And so I was just wondering, listening to Jim talk about less, 1/5 of eligible beneficiaries get this service. Let's do more of that. Let's not overthink it. Almost, it takes going to take a lot of thought about this, but it's almost like there's a method here we could use TCMs as a bridge to its own upside shared savings model. Just doing the service, if you show that you reduce outcomes, you get part of that savings back.
Yeah.
Just a wonderings.
Totally agree, Lee. Appreciate all the conversation and the presentation again, Walter, and thanks to the PCD team for putting all that together. We're going to take a quick break now until 10:40, and at 10:40 we'll come back and hear our first panel discussion. Thank you. Welcome back. Earlier this morning we had a great presentation from Walter and the PCD team that shared their presentation around care transitions. And this is going to be the topic for the rest of the day and tomorrow. And now I'm excited to welcome our first panel discussion. At this time, I'll ask our panelists to go ahead and turn on their video if you haven't already done so. Thank you. In this session, we've invited 3 esteemed experts to discuss improving management of care transitions from facilities to the community. After each panelist offers a brief overview of their work, I'll be asking them questions. PTAC members, you'll have an opportunity to ask our guests follow-up questions as we go and encourage your participation. The full biographies of our panelists can be found on the ASPE PTAC website, along with other materials for today's meetings. I will briefly introduce each of our guests and their current organizations and give them a few minutes each to introduce themselves. First, we have Dr. Karen Johnson, who is Vice President of Practice Advancement at the American Academy of Family Physicians. I'll note that AAFP submitted a proposal to PTAC in the past. Karen, welcome. You want to introduce yourself?
Sure, thank you very much. Good morning, everybody, and thank you for the opportunity to be part of this important discussion. I am, as you said, Karen Johnson, and I am here on behalf of 129,600 members of the American Academy of Family Physicians and other primary care physicians and teams essential to facilitating smooth transitions that result in better outcomes, including improved equity for patients. I currently serve as Vice President of the Practice Advancement Division, which works on payment practice and career-related policies and education on behalf of our members. My comments today are also informed by a wide range of perspectives. Can we go to the next slide, please? I apologize. Thank you. By a wide range of perspectives I've gained through my work as a benefit consultant to self-funded employers. Back to the last slide. Oh, sorry. I'm misreading the slide. It's early on a Monday, folks. Worked as a benefit consultant to large self-funded employers and union trusts, health plan payment strategies, including primary care and value-based payment design, and also was privileged to work on a number of multi-stakeholder data-driven improvement initiatives. Next slide, please. So from a primary care perspective, or really any practicing physician perspective, there are really a couple of essential ingredients in successfully supporting care transitions. One is that you have to know that a transition is taking place to activate your team and your resources. And secondly, you really have to be equipped with the level of resource needed to support that patient successfully through their transition, whether that is within your practice or whether that's a resource that is needed in the community that you are there to facilitate and support engagement with on behalf of your member or on behalf of your patient, excuse me. Unfortunately, barriers to this happening continue to persist.
Karen, we think we've lost you there. Can you hear us?
Continue to get in the way of primary care practices receiving timely and actionable information about their patient population. One of the core principles represented in the AFP Guiding Principles for Value-Based Payment, which were adopted as policy by our membership in 2022. And when we talk about solutions for care transitions specifically, it is important to recognize that any successful improvement initiative must be embedded in a complex maze of policy and practice considerations to have meaningful impact. We know that the typical primary care physician caring for Medicare patients may coordinate care with as many as 229 other physicians working in as many as 117 different practices. When one considers the number of disparate EHR systems, each implemented, as we know, in its own unique way, the challenges to information sharing through that mechanism are really strong. So given the visibility that payers have into the overall patient's care journey, we believe they play a really important role in this multi-layered strategy. How they choose to approach their role can be a help or a hindrance, as practices frequently contact with 7 to 10 or more payers. If each payer, whether public or private, selects its own, quote, solution for ensuring physician practices receive timely and complete information, it may look like a very elegant solution from the payer's point of view. But when viewed from the perspective of the primary care practice, their elegant solution has the potential to be very disruptive to internal practice workflows, and it cross purposes with their primary aim of really ensuring high quality care for their members. So finally, while information is essential, and you will hear that reflected in the discussion that we have today, the primary care practice's ability to activate, to actually act on that information is compromised if we continue to rely exclusively on an undervalued fee-for-service payment for primary care. Essential to primary care practice's ability to be part of the solution to the very complex problem laid out so well by Dr. Lin and the team that supported him is increased investment in primary care. This increased investment must include population-based payments that provide sufficient funding and the flexibility to invest in the teams and the resources they need to best address the needs of their patient population. We are so pleased to see this topic on PTAC's agenda and appreciate being included in today's discussion. Thank you.
Thank you, Karen. Looking forward to some discussion around that. Next, we have Dr. Scott Berkowitz, who's the Chief of Population Health Officer and Vice President at Johns Hopkins Medicine. He also serves as an Associate Professor of Medicine and Cardiology at the Hopkins School of Medicine. Scott, please introduce yourself.
Good morning. Thank you so much for the opportunity to join you all today. I really appreciate it. Can you please move to the next slide? So I am Scott Berkowitz, as mentioned. I'm a general cardiologist, but I'm also the Chief Population Health Officer and Vice President of Population Health for Johns Hopkins Medicine. By way of background, I've been at Hopkins for about 20 years now, for the last 3 in the role of Chief Population Health Officer. And predating those efforts, I was involved in helping to stand up our accountable care organization, some of our efforts with post-acute care collaborative development, as well as a program we had in partnership with CMMI to develop the Johns Hopkins Community Health Partnership, which was one of the HCIA Innovation Awards. In late 2020, we launched the Office of Population Health to standardize, coordinate, and deploy population health activities and services in a strategic and data-driven way, really with a focus on enhancing value and reducing disparities. There are 5 key functions related to high-value care that the Office of Population Health seeks to support. Those relate to health system coordination on system-wide population health projects, program leadership for population-based care contracts, programs, and grant awards, clinical services to support our patients in optimally managing their health and social needs, and of course, with a need to focus, one of our principal areas of focus has been around high utilizing and high-risk patient populations. Developing of a data analytics platform to enable data-driven support, and performance management across various health system and entity population health matters. And in terms of population health, the way we've organized ourselves relates to delivery of clinical services, community health, administrative services, as well as analytics, population-based analytics. Next slide. So Johns Hopkins Medicine is headquartered in Baltimore, Maryland, a $10 billion integrated global health enterprise and a leading academic healthcare system in the U.S. It includes over 40,000 full-time faculty and staff, operates 6 academic and community hospitals, 4 healthcare and surgery centers, more than 6 ambulatory surgery centers, and 2.8 million outpatient encounters per year. Plenty of background to be shared if it would be helpful. Next slide. So what we're here today to talk about relates to care transitions, and I will suggest that increased patient complexity and reduced system capacity are really important components of that. Our patients require transitions of care from the hospital as well as from other locations that address post-discharge clinical needs while also addressing social determinant of health issues. Growing patient complexity has complicated this transition. I oversee the ambulatory care management, behavioral health, and the other elements of that cross-functional care team. I don't directly oversee the inpatient care management teams, but we partner together across the enterprise related to care that is delivered. In terms of efforts that are involved in addressing this from a transitions perspective and work that we've done related to JCHIP and other areas, the bundled hospital discharge strategies allude to some that Dr. Lin and team had mentioned in the preview. But some of these components, including risk screens and tools, interdisciplinary care rounds, patient family education, medication management, primary care handoff, emergency department management and protocols, and just overall transitions of care support, such as transition guides, a patient access line, as well as other areas. Next slide. The Office of Population Health has a cross-functional care team, which includes care management, behavioral health, community health workers, and pharmacists, which work together and partner, and we seek to identify patients through analytic mechanisms as well as provider referrals, and to try to connect them, particularly at the time of hospitalization, but also when they're not hospitalized, to support improved management of those patients and seeking to understand and address their needs. And as also mentioned, one of the things that Johns Hopkins Medicine is also engaged in is related to a post-acute care collaborative development, facilitating discharges to SNFs. And there's been significant evolution through COVID related to these types of partnerships and working on our care continuum efforts. So the partnerships and the continuum and the way in which we help navigation of patients through the continuum, I think, is another important area which will come up today. Next slide. That's all I have. Thank you.
Thank you, Dr. Berkowitz. Next, we have Dr. Robert Zorowich, who is the Regional Vice President of Health Services for the Northeast at Humana. Bob, welcome. You can share your slides.
Sure, if you can go to the next slide. So yes, I am Regional Vice President for Health Services for the Northeast region of Humana. Humana, as you know, is one of the larger providers of health insurance, particularly Medicare Advantage. As Regional Vice President for Health Services for the Northeast, I oversee utilization management and all clinical activities from Maine down to Maryland. We provide Medicare Advantage plans to all of those markets. My background is I am a graduate of Albany Medical College, and I am boarded in internal medicine and geriatric medicine, as well as hospice palliative. Prior to my current position, I spent many years in clinical practice in the office, hospital, and a number of years working in nursing homes, as well as medical director of hospice and home health agencies. I think germane to this particular talk, I've been the American Geriatric Society advisor to the AMA CPT editorial panel since about 2003, and helped draft the Transitional Care Management Services CPT codes 99495 to 99496 about 10 years ago or so. I'm gonna, if you can go to the next slide. I'm not going to go over this because actually a lot of this was covered in the presentation just prior to this. This is just a summary of some of the evidence of transitional care models. And I wanted to just include this in the slides because it was studies like this that informed our development of the codes, mainly the work of Eric Coleman and Mary Naylor. If you can go to the next slide. It's not time for the break. Sorry. Is my appendix there? I do have in the appendix the text of the transitional care management codes. It's not necessary that you see them, but what I wanted to mention, because I know this is part of the discussion, and as you know, the TCM codes 99495 and 99496, while utilized, have had a rather slow uptake and have not been used as often or as frequently as we had hoped. We did draft them based on the evidence, mainly of Dr. Coleman's and Dr. Naylor's work, and we tried to jury-rig the components in their research that they showed evidence for effectiveness into the format to make a Category 1 CPT code family as per CPT Category 1 requirements. So I wanted to give that background. Remember that these are physician-based codes. These codes were rather unusual at the time in that they involve not only physician work, but also the work of physician-supervised clinical staff. And they were essentially global codes over a period of 30 days from the date of discharge, which at the time was rather unusual. We modeled it somewhat on the ESRD, end-stage renal disease codes, which were 30-day codes, as well as looked at the rehospitalization metric from CMS, which was a 30-day rehospitalization, and that's why the 30-day global period was chosen. And in order to use these codes mainly for patients that really needed them, we confine them to those that would require moderate or high level complexity in decision making. We've already talked about in the prior presentation that the uptake has been rather slow, but there are other models that can be, I think, jury-rigged into these codes. They do leave a lot of room for different types of models, so long as, according to CPT, they are under physician supervision. And I think I will leave it at that, and we can talk about other models and other issues as we go on. Thank you very much.
Thank you, Bob. That was very, very helpful from all three of you. And we're looking forward to this conversation because I think the PTAC committee realizes how important and possibly underutilized transitions of care is and what an impact it could have, at least from the literature we've seen. And so we're really looking for your perspectives on this as we go through the rest of the morning. And I'm going to ask my PTAC committee members, colleagues, to put their name things up when they're ready for a question. I'm going to start out with one question, and then I know we're going to have a lot of questions from the group. So given the importance of the transition in care processes, and sometimes how complex it can be, who do you all feel should be primarily responsible for managing those transitions across the continuum, if there is a single primary person responsible? And if there is, what provider would that be in your opinion? And I'm going to start with Karen on that.
Thank you, Dr. Sinopoli. I want to do just a sound check first because I understand I was cutting out a bit in my introductory comments, and I hope that you're hearing me. It looks like the team is telling me in the background that I'm coming through now, so that's good. Yeah, so, I think from our perspective, we certainly understand and believe that the primary care physician plays a really central and important role in the ongoing care of patients. And so therefore, I think there is an important priority in engaging them early in the transition process, giving them full information, as I mentioned previously. We see that as one of the most important systemic barriers, also called out earlier by what, and I may pronounce this incorrectly, I apologize if I do, by Dr. Polaru in the comments about just receiving notifications. So you can't be responsible for something you're not aware of that is happening. But I think we believe also that every provider or physician or other clinician involved in the care of that patient plays a really important role. And sometimes that's just tapping the primary care physician on the shoulder and making sure not only that they know that the transition is happening, but they also receive full information. So a warm handoff as opposed to an alert in many situations can go a long way in facilitating that accountability. But while we think that, again, that primary care physicians, family physicians, and others in those roles play a really important and central role in the ongoing care, I don't think that diminishes the responsibility for others in the transition process to be really active participants in the engagement of that primary care team.
Perfect. Bob?
Thank you. I would tend to agree with Karen. I do think that transitional care management is a team effort. I do think because of the clinical complexity of these patients, that it should be overseen by a physician or a non-physician practitioner, such as a nurse practitioner or physician's assistant. But as you know, some of these models, for instance, the care transitions model may be led by a nurse, but of course the physician is going to have a critical role. And in in Project Red, there's a virtual patient advocate. Now that's actually a discharge planning model that is complementary to transitional care models. But I think it's important to underline the fact that there are really important leadership roles that don't necessarily have to be filled by a physician, but I think that the clinical complexity in synthesizing information and working together with the team and coming up with a coherent and consistent transitional plan, I do think requires the clinical skills of a physician.
Scott?
Yeah, thank you. I agree with both Karen and Bob's comments that ideally the primary care provider is the leader of that work. But I do believe it is a team-based approach and a team-based model, and having strong care coordination, care management team members that can help support the provider and working top of license and helping to work with them to support those needs across the continuum, I think is really important. One area that I alluded to in my earlier comments relates to multidisciplinary rounds. And at that time, when a patient is hospitalized, there are physicians and all the different types of support staff are participating in a unified discussion around those patients' needs and ensuring that they're being advanced through the care continuum towards discharge and with appropriate follow-up. So I think that's another example of where team members working together and facilitating connections between inpatient, outpatient, and other teams that's patient-centered is particularly important. And as those patients move from hospital to next of facility, whether it's a skilled nursing facility or other facility or back into the home, we need to be mindful of the different needs, constraints, and challenges that may exist within those care settings to support the needs. And while there may be more resources available in a hospital setting, there may be fewer available in some post-acute care settings, but then that transition back to community-based care and primary care is nonetheless important, and it's just a matter of making sure that that continuity can be maintained.
Perfect. Thank you for that perspective. Larry, I think you had a question.
I do, and I guess it should be best addressed to Robert, but any of you can comment as well. In today's complex environment for inpatient care, patients are not being taken care of by one physician. There are multiple specialists involved in just about every admission to a hospital today. Also, the physician that is taking care of the patient for primary care versus each specialty is most often not the one that's seeing the patient in the outpatient setting, since we have hospitalists and we have now specialty hospitalists. So the transition of care is one that requires transition for more than one specialty. Certainly, I welcome the need for the primary care doctor to have a TCM code, but I can see a need for it in the specialties as well. So my question, Robert, is at CPT, why did you limit this to just one provider to be able to bill for a TCM code?
Do you have an hour? So let me say that the TCM code can only be submitted by one physician. However, that does not necessarily have to be a primary care physician. I do think that part of the TCM services that are involved in the code involve coordination with specialists. So the physician or the clinical staff would have to, as part of transitional care, be in contact with the specialists. The other thing I wanted to mention, and I think is really important, because transitional care really begins with day one in the hospital, and with discharge planning and doing an assessment of what that patient's function is, what the patient's behavioral health issues are, what kind of resources they need, what kind of social determinants of health deficits, and going towards discharge, getting them ready for discharge, and then providing a meaningful discharge summary, which is often very perfunctory and devoid of a lot of good content for the primary care doctor, if the primary care doctor is not the one taking care of the patient. The primary care doctor then would be armed with enough information with clinical staff to be able to perform medication reconciliation, identify the specialist that the patient needs to see, and use clinical staff in order to coordinate that. And that would include speaking with the specialist and making sure everybody's on the same page. This is a lot of work. I understand the point that a specialist may also have a stake in this and may perform some of these tasks. But I think that the one physician who is going to submit this code should be the one, along with clinical staff and the team, in coordinating everything and putting together the transitional plan. I hope that answers the question.
It does, but that's clearly not what's happening in the real world.
I don't disagree with you. It's very difficult, and I think one of the reasons you see slow uptake of the code is that it is very difficult to put together the organizational structure, the culture, the training, and the commitment in order to provide this kind of service, which is complex.
Karen or Scott, y'all have any additional comments?
I'll just reiterate Bob's comment about the importance of good communication across teams and the importance of specialists and being a part of that broader care team structure and process. And within our hospitals and other care teams, we have some patients where specialists play an increasing role based on patient complexity and the needs of those patients, whether they are cardiovascular, such as myself, or behavioral health or other areas of importance. And so I think it's good to think broadly about that and to recognize the important roles that, although as I answered the last question, I think primary care is suitable to be the quarterback. There are situations where increasing roles of the specialists can be really important into managing the complexity of those patients and to positioning them for success as a part of a broader care team.
If I can just say one additional word, I'm sorry. I'm sorry. I hope I didn't interrupt. The TCM codes were really conceived as part of CPT physician fee schedule. it's not the only way to pay. In value-based arrangements, you're going to have a lot more latitude to develop different models. So if you're talking about getting specialty involvement and having specialists be part of the team, you have a lot more flexibility in a value-based arrangement to do that than you do with the rather narrow structure of CPT codes.
Yeah, so I was going to say almost exactly what Dr. Zorowitz just said, which is that I understand that the question was about the TCM code per se, but I think the relatively low uptake of that code, I think as interpreted by the study Dr. Lin cited, said that was an indication that the services were not being provided. I think based on what we hear from our members, many of the services that constitute components of TCM are really being delivered, but not being billed by that very specific code. And that's why I think at the Academy, what we are really, really leaning into is this idea that we really do have to move away from fee-for-service payment, whether it's a more comprehensive code like TCM or some other very unit-specific code, toward more population-based payments embedded in a value-based payment structure. So that's the piece, I think, because I do think Dr. Zorowitz's point about how complex and difficult this is true, and how it's delivered in any given geography or practice setting may look different based on the needs of the population and the resources that exist in the community to support those practices and their patients. So the flexibility of those population-based payments outside of the fee-for-service sort of requirements for documentation and coding are really, really important.
Yeah, thank you for that, Karen. Jen, you had a question?
I want to thank each of our presenters, but my question is for Dr. Berkowitz. As you described, Hopkins is an multi-inpatient facility healthcare network, including academic and community practices, and you practice in a pretty unique state with regards to population-based payments. So my question for you is, what's working well with the current payment model around population-based payments in this transition of care space? What is not working well? What is good care that's not being incented? And what might be some perverse incentives that you're currently seeing in this space?
Sure. Thank you very much for the question. By way of background, I'm sure many who are participating are aware, but Maryland is what's called an all-payer state through an arrangement that exists between the Health Services Cost Review Commission and CMMI through a waiver that's been in place for decades to make it what's called an all-payer state, meaning the cost for a hospitalization for Medicare is the same as Medicaid, is the same as commercial. However, that may change month to month. So the cost of a hospitalization may be one amount in 1 month and then change through a rate setting process the next month. Part of the reason it's been constructed in this way over time was to enable further planning related to coordination in this way. And the idea of, since all patients are discharged, it's nice to imagine a way in which you can think about all payers. And from that perspective, part of the evolution in Maryland has been that there's been enhanced focus, I would say, on the Medicare side, and the Medicare side having a total cost of care framework, because a lot of the oversight is of the hospital side, but they've been able to implement a total cost of care metric and to start to think about what that looks like more broadly across Medicare, and to try to move in that direction. So what I would say is, one positive is the potential to continue, and the opportunity is to grow, to be able to become increasingly all payer with respect to that, and to create services and opportunities. A lot of the services that I described for our Office of Population Health come from what's called the Maryland Primary Care Program, which is analogous to CPC Plus, and has started with Medicare and enhanced revenue to support investment in care coordination teams. And it takes, as we've talked about, it takes a village to do that. And The support of that has been primarily, as I mentioned, on the Medicare side. There's opportunity over time to be able to take that more broadly. And I think that that's a really exciting opportunity. As a state, we're not quite there yet. We're on a journey. And so I think that that's positive in terms of the flexibility and what that allows you to do and to create over time. Part of the opportunity, I would say, is inherent in some of the complexity that I just described, which is that the ability to have changes such that you can reduce utilization, reduce hospitalization, and that can end up translating to an increase in cost through the math is sometimes challenging to fully understand, and how it then changes such that the pricing for hospitalizations, for example, can change. And so I think that that's hard for sometimes for frontline workers to truly be able to wrap around. If you're trying to develop strategies and approaches, it's really important to understand the framework with which you're operating under. And I think there's a lot of good work that's being done to help to support that, but it can be challenging at times to fully wrap your arms around what can seem to be a change based on utilization versus cost that may not be aligned in the way it might be in other traditional payer-based models. And it can be sometimes harder to fully win hearts and minds, I think, of clinicians if they don't fully understand more around what's trying to be achieved there. But really focusing on the key goals and what we're trying to do for our patients to support quality and reducing avoidable utilization and how that produces improved health is important. And I think that there are opportunities that are created through a lot of hard work and collaboration to have gotten us to where we are today. I hope that was responsive. Happy to elaborate further.
Bob, Karen, anything to add to that?
Okay. Not for me. That was very good.
Lauren, you had a question?
Excellent presentations, very helpful so far. I'm interested in asking you about health-related social needs and health equity, and how are relationships in the community impacting the way that you look at build of partnerships, potential shifts in payment, and also structures that are creating effective relationships in the places where people spend the most of their time, and what roles and disciplines are emerging as key partners in delivery of effective care transitions.
I'd be happy to jump in on that one first, if that's okay with my panelist friends. Yeah, it's such a great question and so important to really all aspects of care, but especially these care transitions, which we know are so often hindered by a person's social circumstance, whether that's a lack of care support at home or inability to new meds or to get to the follow-up services and care that they need. So we, believe that all physicians, at all points along the spectrum, everyone should be attentive to an individual's health-related social needs and probably looking at through the lens of care that they're delivering at any point along the process. But know that primary care physicians, given the longitudinal and trusted relationship that they have with their patients, have the most visibility and insight into what those health-related social needs are. I'd say there's a couple of points that I would want to make here that I think are really important. One goes back to this sort of common theme of information sharing. I think for us to collect that information and not to share it as in secure and safe manner with other physicians and care teams that the patient has selected as their trusted partners in their care journey would be a mistake. And I think building mechanisms for doing that is really important. So as that information is collected at different points in my care journey as an individual, I want to make sure that all of my those that I trust with my care are receiving information to help them help me in the best ways possible. So I think that's one aspect of it. I think the other aspect of it that we think is really important is that no physician, whether primary care or others, should be held accountable for addressing social needs, complex social needs, when the resources to do so don't exist in the community. That's not built into healthcare payment, is to build social supports. I think to connect to social supports in the community is a really important aspect of the role that all physicians play, but especially primary care physicians. At the AFP, we are strongly in support of community-based infrastructure that helps community-based organizations build strength as a network that can support and facilitate addressing health-related social needs identified in the healthcare ecosystem. So the idea of a community care hub, where that information, where that resource exists to facilitate really effective and community-centered and patient-centered interactions, we think is an essential to moving us forward from where we are today.
Scott and Robert, did you want to add?
Sure, if I can add to that. It is a real struggle to identify resources to address food insecurity, housing insecurity, transportation insecurity, and other social determinants of health, and find organizations that can provide it and connect patients with those organizations and pay for it. I can tell you that many payers, us, but not only Humana, most of the Medicare Advantage payers are looking for ways of identifying organizations that can provide connections with agencies and other organizations that can address social determinants of health. One nice thing about value-based agreements is it does give you some room to provide, and even if it's a fee-for-service arrangement, payers are interested in finding ways of connecting patients with resources to address their social determinants deficits. This is not easy, but I believe that it's necessary. But again, I believe it starts in the, if someone is in the hospital, part of that discharge plan needs to include identifying those social determinants and, if possible, identifying ways of addressing those before discharge, and then communicating that in the discharge material. I don't want to say discharge summary because that's usually a perfunctory narrative, but the discharge material from the hospital should be more comprehensive. If it's going to a primary care practice that did not admit the patient, if that's information there and a lot of these connections are already jump-started, I think it makes a lot easier once the patient is out in the transitional period to make those connections. But again, this is a very complicated process.
So I'll just add, I appreciate the comments by both of my colleagues and really appreciate the question, because you're absolutely right. At the heart is that social factors have a huge impact on patients' health and our ability to provide care delivery for these patients. And I think that it's been studied before, and it can be a really sizable important part of that role, because if they don't have certain issues that may be addressed related to their social factors, then they can't really focus on other clinical factors that they need to be able to have addressed. And so you need to be able to think about them holistically. This directly impacts on the way that patients move through care delivery towards other care settings. Like, for example, if you're trying to appropriately manage a patient and then preparing them for discharge through a screening process, and then that patient may have certain needs that are related to these factors, which may directly impact on their ability to go to a next of care facility to be able to get the supports that they need. And so this can be really critical to be able to understand that and to be able to have enough of those supports. We are fortunate through some of the initiatives I mentioned through the Maryland Primary Care Program to get some funding, which is called HEART funding, which is specifically related to health equity, to support some of these needs. And we've been able to help match both for transportation and some food insecurity issues to be able to support some patients with this. But this is not necessarily for all patients. Again, as we're talking about, it's patients of particular programs. And when you're talking about areas that are, critical, like housing or things like that, we may not have solutions for how to help settle some of the social issues like that. And so what I think is equally important in a dialogue around this with all the esteemed colleagues who are in the room and participating in this is, how does everyone work together in a multi-stakeholder and collaborative way? Some of these are public health related issues. Some of these require local, municipal, city, state, other supports and arrangements and partnerships to solve these issues, or even to continue to move them in the right direction absolutely requires people working together. That doesn't mean that healthcare providers and teams and plans shouldn't be partners in that, because they absolutely are. And I think that's something that we're really working hard on. But recognizing just how important this is and how overarching it is, and continuing to think about broader stakeholder solutions to that, I think is really important. And I'd be happy to elaborate on any of that further.
Thank you. Really valuable perspectives.
This is
Or
Angela.
if I may I do one quick follow-up on that?
Sure.
Yeah, so I really appreciate all the comments, Dr. Berkowitz, the sort of the shared, this is a problem begging for a shared investment solution model. And the multi-payer and multi-stakeholder approach to that, I think, is so important. I just wanted to call attention to one of the initiatives that the AFP has been participating in and thinks is really important around this community care hub concept that I mentioned, and it is the Partnership to Align Social Care, which is really focused on the build out of the community-based organization network in communities. So most community-based organizations not equipped to receive referrals from 10 different prayers and 40 different practices, but they might be equipped and resourced to engage with a central mechanism that's built with attention to their needs and their capabilities. So I just want to underscore that point of shared investment and multi-stakeholder engagement as such an important path forward here.
This is Angela. My question is kind of tangential to this conversation. And I'm interested in your perceptions around transitions to home from the hospital as opposed to going to a SNF for those patients that have complex needs. And as we know now, the path of least resistance a lot of times is for hospitalists just to discharge them to a SNF. And so I'm just curious, what are your thoughts about how we can improve care at home, not necessarily just traditional home health, but what does care at home look like? And can you comment around how to, if you know some innovations around that and how we can fund that differently than we're doing today? Start with Scott.
Happy to comment. Really appreciate the question. It is important to think about that transition. That is likely the most common transition, is a patient being discharged from the hospital to home. And one of the cornerstones that I would suggest is that communication is really key. We've talked on this call so far today about discharge summaries. We've talked about communication between care team members. We've talked about many other areas of communication. And we've also talked about the fact that considering the discharge to home is really something that needs to start at the outset of the hospitalization, really from the very beginning, bringing together a multi-stakeholder team to think about and assess appropriately what the patient's needs might be post-discharge, and to be able to bring together the stakeholders to work to facilitate that, knowing that sometimes that might take a little bit of time and planning to bring together, whether it's rehab needs, whether it's home care needs, as you mentioned, whether it's support for particular disease type conditions, if you will, like heart failure follow-up, post-acute primary care visits, things of that sort. And so, as I mentioned a little bit earlier, one of the things that we do is we have a focus on sort of a bundle of discharge strategies that is hoping to sort of engage around all of these areas, one of which relates to sort of a risk screen or a tool to help to anticipate what those needs are. One that was mentioned, I believe earlier, was ESDP, early screen for discharge planning. And there's also a activity measure for post-acute care, which helps folks to understand what the activities might need. There's also embedded flags in the EMR, which can help you to understand and anticipate who might have higher risk or higher needs that you can really be working around. Then you bring together that interdisciplinary rounds, which is really, for us, is usually daily, to focus on these different issues to make sure that you're able to communicate well within the team and prepare. Education is key with patients, families, caregivers, and different tools to help to support that. Medication management, the idea of getting as much as possible, trying to make sure that these medicines can be in a patient's hands before they leave. And there is a lot of complexity around medicines and different medicines, which can be really higher risk. You know, and I see that in my practice, a patient who comes in on 20 medicines, and even if I have help there, I know how much complexity there is in terms of those medicines and planning around that. That primary care handoff, and we probably have all seen in different ways some strain related to access and capacity there. And so what does that look like? In some places, we've been able to have what's called an aftercare clinic to support some immediate handoff needs related to that. Work with the emergency department and transition guides through some of the models that you alluded to earlier in the presentation. Things like transition guides, patient access line, phone calls to people to make sure they were able to get their medicines and to follow up, as well as other social work and referrals. And so I think that those are some of the different strategies that can connect in particular. And I would also just add, bringing back to something that I mentioned earlier in the social context, is the importance around behavioral health and substance abuse challenges and other issues regarding behavioral health needs, and really trying to connect around that, because that can have such an important impact. And these numbers and frequencies have really increased so dramatically through COVID. And we really need to make sure that we're helping to address those patients' needs to help them get to the other clinical supports that they need. And so those are what I would say to your question is sort of an aggregate of some of the areas that we need to work on together, and ensuring that those resources can be provided across a multidisciplinary, cross-disciplinary manner for those patients as they are transitioning from a hospital into the home.
Karen or Bob, anything to add to that?
Yes. I think that the age-friendly health system, by definition, addresses much of this by identifying the major domains that are necessary to address in order to effect a safe and timely discharge. Mobility, mind, medications, what matters most to the patient. This includes things like social determinants of health. And as a member of the American Geriatric Society, we like to add a fifth pillar in there, polymorbidity, because many of these patients have multiple morbidities that interact with each other and make it even more complex to manage them. When discharging patients, it may be necessary to provide some services besides just referring them back to their primary care doctor. They might need home health, for instance, doesn't include a physician necessarily or a nurse practitioner visit at home. And that may be something that is necessary in the short run before the patient is able to get back to the office. And it may even provide better support than just going back to the office, in that a clinician going into the home can see for themselves what are the barriers to maintenance of health in the home. Are there medications stuck in the medicine cabinet that were not previously identified? So I think that we need to have a much broader view of what kind of discharge services would contribute to an effective transitional care plan. And this is not all obviously included in just performing the TCM CPT code. This is really having a much broader view. It also depends, I want to add, on the organizational structure. So I think Dr. Berkowitz is very fortunate to be in a highly developed integrated health system. And that allows the use of resources that may not be available to a small practice or even to one of these larger network practices that are growing more and more every day. And that allows for more integration and communication, whereas independent practices may have to find ways of communicating and creating partnerships with other organizations in order to provide the services necessary.
Karen, you might be on mute. Karen, we can't hear you. You might be on mute.
Hello? Yeah,
we can hear you now.
Okay. So the comment that I was going to make is that, sorry about that. Couple of points that I want to underscore that have already been made. One is that discharge planning starts when the admission begins. And so that initial notification to the primary care physician at the point of admission is so important. they not only need to begin to activate and engage within their care team, but they can also inform the care that happens in patients or in other care settings based on their knowledge of the patient, particularly around health-related social needs, given their degree of knowledge and understanding of the patient is so high. In terms of transitioning out into home, access to just the basic essentials that they need in terms of medication and equipment that often comes with the transition in care. Sometimes those are complicated by things like prior authorizations that get in the way or delay care. So thinking about how those are eliminated at those critical moments in the patient's care journey are important considerations. And then also, we've talked a little bit about staff and the robust staff required. This challenge that we're all having around staffing adequately to meet just our organizational needs in terms of taking care of patients, whatever that setting is real and probably not easily solved by any single policy. But we know that payment and just being able to offer competitive wages to those folks who do the daily work of taking care of patients in transition, home care workers, aides, and others, is really essential and critical to making sure those resources are there when we need them.
Thank you for that. I think we had Lee next and then Lindsay. At least passing Lindsay.
Thank you. I think, Karen, you talked a little bit about this in your opening remarks. So I'd love to hear further on your perspective, and I think also from Dr. Zorowitz. But as payers, PCPs, ACOs, or other risk-bearing entities try to improve outcomes at care transitions, the risk of duplication of efforts is very real. I think especially as we think about older adults, patients with complex chronic conditions. Good intentions lead to confusion. I see this especially in my older adult patients. How can payers and other stakeholders that are trying to improve outcomes at care transitions be incentivized to work together as opposed to duplicating efforts and risking confusion for patients?
Okay? I'm back now. Sorry.
Yes.
I'm doing a workaround here on my technology issue. So thank you, Dr. Botsford. Really great question, and one that we are really looking at closely, given the high level of activity we have seen from payer-directed care. So again, I think very well-intentioned resources put in place to care for their members. The complication, as we know, that creates is when you look at it from the primary care practice perspective, that may mean 7, 10 or more different sort of interventions across their patient population, depending on who the payer is, to keep track of and pay attention to. So I think we believe that the payment model, the value-based payment models that sort of are really clear about who is accountable for what, and making sure that those payment models are sufficiently resourced to provide care teams, again, with the flexibility, but also the level of resource they need to care for their patients is essential in moving us forward. I will say, though, that one of the things we are observing in many of in at least some of the payer behaviors around some of this is an increasing recognition that the patient's primary care physician relationship in the community is paramount to their ongoing sort of improved outcomes for their member population. So again, going back and forth between who's a patient and who's a member, it's the same person, but we look at them differently depending on the organization we are representing and working for. We have seen increasingly that payers are recognizing that relationship and proactively reaching out to primary care physicians and advising them when they have engaged with a vendor solution, and we see a really growing number of vendor-driven solutions. But when there's a vendor solution in place to care for a unique population or a very specific need for those members, we are seeing increased communication from the payers to the physician practices, which we applaud and appreciate. I think it does not solve the problem that you're talking about, which is the patient is often left out of that communication and therefore confused as to who's doing what on their behalf. So I don't know that we have all of the answers to how to effectively solve that, but I do think that beginning to sort of be more explicit about what role the physician and their care team is expected to play under the payer's payment approach versus the care that they are delivering is really important. But again, we believe that the care belongs in the primary care practice with the physician-led care team, and that it's the payment models that support that delivery model that are those that we need in place today.
I'd like to add to that because I think that was a very perceptive response. From the payer's perspective, you know, a payer has multiple practices and hospital systems and other practitioners. Some of them are capable of performing these activities, many of them are not. The payers are very interested in seeing these services provided because they know it improves care. And of course, they're interested in reducing costs. If it was aligned that payment, particularly value-based payment, supported those sorts of activities, and the practice had the economies of scale and the information systems and the communication channels in order to perform those services, the payer wouldn't have to do it. The payers are doing this in order to fill in the gaps that many practices cannot fill. And I think at the larger practices that we've seen that can provide these services, it's not necessary to fill it in. But those are few and far between. And I think as payment models, incentives, and the organizational structure of the practices evolve, I think you're going to see the movement of those activities more to the practices, because as Karen says, I think that's where it should reside. The payers, remember, don't have the clinical information. They have claims information. They have some clinical information if they have hospital records because of utilization management, but mostly they're dealing with claims information. It's the practice that really has the real important clinical information and knows the patient. So I think that down the road, as these payment models evolve and as incentives and metrics align with them, and the practices develop the organizational structure and infrastructure in order to support these activities, that's where it's going to reside, and that's where it should reside.
So great.
Sorry, Scott, I'm going to jump back in here real quickly if I could. Do you mind? I just want to underscore one thing. Thank you, Dr. Zorowitz, for that. And I also, working in a health plan environment previously myself, and really trying to solve for this from a health plan perspective, I do think that that ability to sort of be adaptable and flexible as a payer organization and scaling what you do based on the capabilities of the practices is an important solution in the long run. I think we're probably a long way from getting there. But the one point I really wanted to make here is that we've talked a lot about communication between care settings, the different clinicians, physicians, and others who are caring for patients, and how important that communication is. Cannot underscore how important the communication is between physician practices and the many payers that they engage with. Equally important, and we find physician practices to often be confused about who's doing what on the payer side. And so I just think that's another aspect of this that's a really important ingredient in the overall picture. Sorry, Dr. Berkowitz.
No, those, all great comments. Really appreciate that and appreciate the question. The only thing I would add is that as we think about this, especially as we're evolving collectively to more value-based arrangements, is trying to consider the opportunities for harmonization from that perspective. And I say that knowing fully that patient populations may be different and different payers may support different patients in different ways. But I can tell you on the provider side, practice side, or hospital side, or otherwise, and patient side, that patients can sometimes find it a little bit frustrating if they walk into a doctor's office, and if they're Medicare, they can get this, but if they're Medicare Advantage, they get that, or if they change this, they can get this. And the measures that might be looked at from the provider side might be different. And so to the extent that there's opportunity, partnership related to that between the provider and payer, and an embracing of engagement of the providers in that work, there may be opportunities to have the provider with the care manager partnering with the payers rather than each payer having their own care manager servicing that site. So again, this is a continuum. This is a partnership. This is a not one size fits all, but recognizing the opportunity for the practices increasingly as they're capable to take on that opportunity and to partner and to be thoughtful regarding the data and the care services, I think is a really valuable opportunity as we continue to all move in this direction.
Perfect. Thank you all for that. Chini?
Thank you, everyone. This has been alluded to previously by all of you, but I wanted to crystallize it a little bit more. So I'm a core operator at heart, and when we think about these things, the cost to do this is, in order to be able to do this with the administrative burden, you have to staff in a way that adds at least a few $100,000 to your operating cost for a typical practice. So if you think about that, it automatically rules out small to medium physician primary care groups that can own it. So then it leaves entities that are large clinically integrated networks like Johns Hopkins or my old group that can fund that. And they have the data infrastructure and EMR basis in order to be able to get that sort of instant information in order to make it happen and get to outcomes. Or you have to be in a total cost of care, value-based care platform. And in the Medicare world, in order to do that, you're in Medicare Advantage for the most part. And so it rules out fee-for-service methodology in order to be able to effectively do it. So it's almost like what comes first, the chicken or the egg, right? And so, what are your thoughts on the fundamental structures of payment methodology that can incentivize a small to medium physician group in order to be able to put the infrastructure in place, to get the communications, to get the ability to get this out of the gate? And if you think large swaths of this country are not covered by groups that are large clinically integrated networks or entities that can do Medicare Advantage at scale, I'd love to hear your thoughts on that.
If I might, that is probably the most difficult question we've had so far. When the TCM codes were devised 10 years ago, and remember it was 10 years ago they were devised, and CPT is very slow to revise code descriptors. So the TCM codes have remained pretty much the same as they were when they were first approved 10 years ago. But the idea behind the codes was not that they were to be used once in a while. It was really sort of a way of jury rigging in a fee-for-service environment, a capitation sort of structure. It's a 30-day capitated payment that includes all clinical staff services plus the face-to-face visit and the phone call and the medication reconciliation. And the idea was that that and the chronic care management codes would incentivize practices to develop the infrastructure in order to provide them. And again, there is that chicken versus egg. I think the issue is, not only can small and medium-sized practices provide transitional care services, but can they manage population health in general, which requires the information systems and infrastructure and organizational structure in order to manage a large panel of patients. And I know that some practices will join IPAs, independent practice associations, or they may associate with MSOs, with managed services organizations, in order to achieve economies of scale, even though the practices themselves are relatively small. So I think there are ways of doing it, but I struggle myself to understand how a small independent practice is going to be able to practice population health without having some sort of economies of scale. And I'm sure they do a great job individually with the patients that they know intimately, and they can take care of them, and they can deal with them on the phone, and they may even make home visits. But in order to really manage a population, I think it does require some economies of scale, and some of these other types of organizational structures may be necessary in order to effect that.
Yeah, I agree with Dr. Zorowitz. This is the hard question. Is how do you do this? Because that chicken and egg continue to sort of baffle us, I think, in terms of solving for this in payment. That's a reflection of the fact that we've been undervaluing and underpaying primary care for years. And so we have the problem that we've created for ourselves as a system. That if we care about primary care's role can be corrected with adequate payment. And I think a course correction, particularly for small and independent practices, is merited. We're so pleased to hear from Liz Fowler this morning and see the announcement about their new payment model. Of course, that's just a limited number of states, but an important step in the right direction. I do think the evidence around independent practices and their ability to improve outcomes is strong. Under value-based payment, I think we've seen it. We know that recent research recent report, I should say, from Wakefield, the actuarial consulting firm looking at MSSP, really underscored that, we know primary care is important, and we know that more primary care visits leads to lower total cost of care, more shared savings. They also saw a difference, though, between those primary care practices that were independent versus those that were a part of a larger health system, that the improvement was even greater for those in independent practice. We know some of that has to do with natural sort of financial incentives, but we also, I think, believe that has a lot to do with a lot of what Dr. Zorowitz just alluded to. Independent practices close to their patients, know them, know how to help support them throughout their care journeys, and are just really good at that. So I think, the kind of prospective payment that we are advocating for in value-based payment for primary care that works well would require some sort of additional upfront incentive for those who are not there today, that need to invest upfront and don't have the capital to do so, which is becoming increasingly challenging in our ever consolidating primary care market. Doesn't mean that those practices don't have the ability to earn that back for those who are making those investments, but we think that those are really, really important. And also believe that there is some discernment that practices need to do around what they should be building on their own versus where they need to be part of a broader sort of shared investment model with others, whether that's other practices in an IPA or through an MSO or some other mechanism.
I'll just add that I agree with my colleagues around the recognition that this typically requires some level of investment to get started, and that there can be different complexities based on the background. A piece that I'll add to this that may be different just by virtue of, as I started to allude to earlier, within the Maryland model, I'll just say that with the Maryland primary care program, the penetration across the state right now is very high across primary care practices, including small and independent groups. And there's financing that's provided through that program. There's complexity related to that in terms of how that ultimately links back to the total cost of care model. So I don't want to say that it's just sort of in a vacuum, but what it has done is it has allowed for investment for small practice, medium, or larger practices to support those needs, to get off the ground related to that, and to have a recognition of what that looks like, and to provide structure around that. So I think as you are considering models, it's certainly one thing to consider among the different types of models that you're thinking about, and the revenue that supports that initiative.
Thank you. I think we have time for one or two more questions. Walter, you want to go next?
Thank you. And I also wanted to just add my thanks to the panelists. They've been really helpful in terms of your insights and perspectives. One of the goals of this public meeting is to try to make recommendations to increase the focus on care transition services through payment model recommendations. And I wanted to circle back to some of the comments that were made after the PCTT presentation by my fellow colleagues, Lee and Larry, in terms of just noting that the slow uptake of the TCM code use and the benefits that such use brings. And this question is primarily to Bob, but I'd love to hear Scott and Karen opine as well if they have comments. But especially since you were one of the drafters of the original codes, I'm wondering if you have any thoughts about why the uptake has been so slow. And then a follow-up question is, how can we increase uptake of these codes as a proxy for use of focus on these services? I know Karen said that a lot of times providers are doing these services without billing these codes, but I think it is probably a good proxy, and wanted to see if you guys have any thoughts about how to improve uptake of these codes.
Yeah, I think there is, in geriatrics, we talk about syndromes being multifactorial, and I think it's multifactorial. Number one is that a lot of physicians are not familiar with CPT, and they don't know that the codes exist, or they don't own a CPT book, they've never read it, and they don't know what these codes entail. That's the simplest answer. I think because of the fragmentation of the healthcare system, the difficulty in identifying patients that are being discharged, in communicating with practices, and practices developing the organization and infrastructure in order to do this, or even to know how to do it, because I'm not sure that physicians are necessarily trained to do this. So I think there's a whole variety of reasons. I've seen small practices, large practices, integrated health systems using these codes. So I don't think it's necessarily closed to even smaller practices, but they need to know it exists, they need to know how to do the code, and they need to plan and get the skill set. I also think that hospitals can help. I'm really intrigued by Project RED, which is cited in the presentation, which is a very robust approach to discharge planning and would give a big jumpstart to transitional care planning, were that information then transmitted in a timely fashion to the primary care doc. It's not exactly analogous, but when I was working in nursing homes and I would be ready to discharge a patient, I would write these very, very lengthy discharge summaries and discharge instructions and medications. And I would ask them, who's your primary care doctor? Call them, what's your fax number? And make sure it was faxed to them upon discharge. And I'd give them a copy and say, bring this just in case they didn't get it. I don't know what kind of assurance hospitals create in order to make sure that the doctors that these patients are going to have to follow up with get all the information they need in order to follow up and create that transitional care plan. So I think multifactorial. I think it begins in the hospital. I think it's skills, training, and just understanding the structure of CPT.
Karen?
Yeah, so it's a great question. And I think that I wish I could see the room, all of you right now, because you're mostly physicians, and I'd love to ask how many of you really want to be coding experts, because I don't think that's what you went to medical school for. And so I think this idea that physicians are going to somehow drive adoption of this code per se is maybe some flawed thinking, because I think physicians really want to take care of patients. And so I think about who our members are and how they were, there's the room. It's like magic. But, you know, more than 70% of our members today are employed. And half of them are employed in large healthcare organizations, hospital or health system owned. Very few really primary care centric. Just 24% of our members are either partial or sole owners of their physician practices. Those are the folks who are really driving how their EMR is structured and set up. And do they bill for this code or that code? And is it easy or hard to document that in a care encounter to actually bill for the code? These complex organizations that have acquired primary care practices as part of their sort of model of care delivery may or may not be focused on the new code that comes out for primary care at any given moment in time. I think we've also know from our members there's been some inconsistency in how private payers have adopted this code over time. I think while we see improvements there, we know that there was a lot of variation in that sort of in the early years. So maybe the incentive to implement that code was not as strong. But I also, so I think those are some of the things that are the challenges that we see that would prevent adoption of the code per se. I guess one other thing I would add, though, there is a practical consideration here for those where the code's on the radar. We understand it. We think it's important. We really should be billing for it, but we can't afford the staff to do the work that's required to bill for the code. So that gets back to the chicken and egg conundrum that we just talked about, that I think is a real and persistent problem.
Scott.
Yeah, really helpful comments from my colleagues. I'll just pick up on the last point that Karen raised, and I haven't heard this really focused on as much, and was around workforce and support care team members. I think the colleagues in the room are all very aware that the workforce considerations have been really significant emerging from COVID in terms of what the impact of that is for nursing and other support. Whether it's in the hospitals, whether it's in post-acute care facilities or other facilities. So we have this situation where patient complexity is growing. The role of social determinant health factors is growing. The role of psychosocial and psychologic behavioral health needs is growing. The ability to move patients from one area of care to an appropriate next level of care is based on the patient being ready from a clinical medical perspective or otherwise, and also being able to have a location for them to go to that's appropriate for their care. And so all of those elements directly translate into the ability to have the right type of staffing to support patients in those needs. And so, for example, one challenge that we've seen at times in some of our urban hospitals particularly is that there right now may not be sufficient capacity in post-acute care facilities to be able to take these patients based on their needs because they are multimorbid, or they have dialysis needs, or they have other types of needs. And if those patients can't get taken to a next level of care, they end up remaining in the hospital longer than may be optimal from a care perspective. You know, every day that you're spending in the hospital that you don't need to be in the hospital is not optimal, yet those patients can't go home. And they need to go somewhere else, but there may not be a somewhere else available. So I think as we're thinking about this and we're thinking about these payment issues, I don't want it to also lose sight of the workforce connectivity to this, to what this means from a cross-continuum model of care, and being able to support those needs and the workforce pipeline to ensure that those other elements of the care continuum can help to support the needs of those patients as well.
Perfect, thank you. Jim, did you have a question? We have a couple of minutes. Okay, good. Yeah, we'd all like to thank all three of you for joining us this morning. This has been very insightful. Your perspectives and actual life experiences dealing with this day in and day out have been eye-opening. It will help us formulate our letter to the Secretary. So again, just really want to thank you. And I think at this time the committee will take a break and we'll be back at about 1:10. So thank you again. Bye-bye.
Thank you.
Produced by the U.S. Department of Health and Human Services.